I would like to take you on a diagnostic adventure. It began one day with a phone call from one of our primary care physicians.
Hello, Roger. This is Elliot Marin. I need your advice. I've just examined a 44-year-old man from Equatorial Guinea. The history he gave me begins about 2 months ago when he began having daily fever and rigors. These lasted for approximately 3 weeks. Subsequent to this, he noted that he had become tremulous. His hemoglobin is 12.4. His white blood cell count is 12,000 with 13% eosinophils. His serum IgM is 2,620, which is about 10 times normal, and his IgG is 3,580, which is about 2 times normal. The malaria smear was negative. His stool examination revealed only cysts of Giardia. His chest X-ray and CT scan of the abdomen had no significant abnormalities. The CT scan of the brain showed ill-defined, low attenuation areas in the white matter of the right frontal lobe and bilaterally in the corona radiata. Do you think he could have an infectious disease to account for his symptoms?
That's a really interesting history. Because of the eosinophilia, the first diagnosis that comes to mind is strongyloidiasis. But that would not explain the patient's fever. Give me his name and telephone number, and I'll make arrangements to see him. Hi, Mr. Thomas. I'm Dr. Bitar.
Yes.
Dr. Marin told me that you were coming here to see me. Our talk confirmed the history from Dr. Marin. However, there was something unusual about Mr. Thomas. It was his face. It lacked expression. I wanted to ask his wife about his behavior, but she did not come with him. So I asked him what his wife said about him. He told me she was very concerned because he was not doing as much around the house, and she complained that he talked less, became upset easily, and was sleeping more.
The interview revealed that 12 months ago the patient had generalized pruritus. 3 to 4 months ago he began to decrease his activities. He stopped working on his car and stopped jogging. He began watching more TV and sleeping more. He became easily upset, had difficulty walking, a sense of imbalance, and experienced frontal headaches. Sometime in the past, Mr. Thomas had malaria. His tuberculin test was positive, 14 millimeters in diameter. Mr. Thomas was born in Equatorial Guinea and lived there about 20 years. Later, he lived in Cameroon and other West African countries for 15 years. During his earlier years in Africa, he had been a farmer and a fisherman. He also lived in New York for 5 years and in San Diego for 6 years. The physical exam was normal except for a 2-centimeter left posterior cervical node and the liver palpable 4 to 5 centimeters below the right costal margin. The neurological exam was normal except for coordination. There was generalized tremulousness noted, especially when stepping up onto something. The tremulousness included his tongue and his arms when outstretched. Finger to nose was slightly abnormal with some ataxia. The gait was unsteady, and he was unable to do the tandem walk.
By the end of the exam, I thought I had the diagnosis.
Those using this videotape as a case to be studied should stop the program here.
I aspirated his left posterior cervical node, but found no organisms in the Giemsa-stained aspirate. I was disappointed. I suggested he have a spinal tap, but he refused. I told him I thought he had a certain illness. He was subsequently seen by a neurologist and did have a spinal tap. The cerebral spinal fluid white blood cell count was 230, the red blood cell count was 2, the glucose 68, the protein 53, and the IgM was 11. This IgM was elevated. Mott cells were also seen, and the slide of the CSF was searched for organisms, but none was found. Later that evening, another technologist examined the slide.
Hey, you want to come over here and take a look at this?
Sure. Oh yeah, what do you think that is?
You know, this is a trypanosome.
My suspected diagnosis of West African trypanosomiasis, African sleeping sickness, was made. Mr. Thomas had a meningoencephalitis secondary to West African trypanosomiasis. T2-weighted MRI images of the brain showed non-enhancing abnormalities of white matter in the right frontal lobe, right parietal lobe, corona radiata, thalami, and basal ganglia, consistent with the diagnosis of meningoencephalitis. However, this did not explain his eosinophilia.
A fresh blood smear was done which showed motile microfilaria. These were identified as Mancinella perstans. One larger microfilaria consistent with Onchocerca volvulus was seen. Skin snips around the shoulders revealed no microfilaria, but skin snips from around the waist, when suspended in saline, showed typical Onchocerca volvulus. An ophthalmologist also identified microfilaria in the anterior chamber of his eyes. Thus, in addition to West African trypanosomiasis, Mr. Thomas also had two types of filaria. Trypanosomiasis is caused by trypanosomes, which are flagellated protozoans transmitted by tsetse flies. When a tsetse fly bites an infected person or animal, the fly ingests trypanosomes in the meal of blood. The trypanosomes multiply in the midgut and go through several stages of development until the infective forms migrate to the salivary glands. When this tsetse fly next bites a new host, these infective forms of the trypanosomes are injected into that host. The Giemsa-stained form of trypanosome in the blood or spinal fluid of humans is seen here as it looks under the microscope. There are two species of trypanosomes which can infect humans, Trypanosoma brucei gambiens and Trypanosoma brucei rhodesiens. These two species cannot be distinguished morphologically. The mature form of the organism is called a trypomastogote. Trypomastogote cytoplasm contains a nucleus and a kinetoplast. There is an undulating membrane which originates in the kinetoplast and terminates in a long flagellum. The trypomastogote is coated with antigenic glycoprotein. Due to genetic mechanisms, molecular variations of this glycoprotein allow the trypanosomes to evade the immune response of the human, thus making it possible for the trypanosomes to survive. It is estimated that there are 20,000 to 100,000 new cases of trypanosomiasis infections each year, although there are no reliable statistics. In Western and Central Africa, Trypanosoma brucei gambiens is transmitted by species of tsetse flies of the Glossina genus. These are found primarily in shaded, humid, wooded areas along streams and waterholes. Rural populations of humans are the primary reservoir in these areas, although Trypanosoma brucei gambiens has been found in domestic animals such as pigs, sheep, cattle, dogs, and some species of antelope, such as cob and hartebeest. Prevalence of infection increases during the dry season when the humans and animals spend more time around rivers or water holes. East African sleeping sickness is caused by an infection with Trypanosoma brucei rhodesiennes transmitted by different species of the tsetse fly in the Glossina genus. These are found in thickets with shade in the East African savanna or wooded areas. Wild animals such as bushbucks, giraffe, and hartebeest constitute the primary reservoir. Humans and their cattle become infected when they enter the bush. Wild animals such as the bushbuck are more tolerant of the infection, but humans and their cattle are not. Loss of cattle secondary to infection with various species of trypanosomes is a major economic problem. This disease in domestic animals of sub-Saharan Africa is called nagana. When a trypanosome-infected tsetse fly bites a human, trypanosomes are injected subcutaneously where they multiply and result in a nodule which may ulcerate. This chancre usually resolves in 1 to 2 weeks without scarring. The trypanosomes next enter the lymphatic system and cause regional lymphadenopathy. Entrance into the bloodstream via the thoracic duct marks the beginning of the systemic illness. This is designated as stage 1 or the hemolymphatic stage. In West African trypanosomiasis, the incubation period from inoculation to systemic disease is usually weeks to months. The onset is subacute, and the illness may persist for years. In East African trypanosomiasis, the incubation period is days to weeks, the onset is acute, and the duration of illness is measured in months. Once in the blood, trypanosomes rapidly increase in numbers and cause fever, rigors, headache, arthralgias, myalgias, and malaise. Lysis of the trypanosomes by antibody and complement are followed by afebrile periods. Unfortunately, the parasitemia and symptoms recur because a few trypanosomes survive the attack of the immune system. At this stage, the trypanosomes have a different surface glycoprotein than they had at an earlier stage. This process is called antigenic variation. Each trypanosome has a repertoire of 100 to 1,000 variable surface glycoproteins. Therefore, waves of trypanosomes can recur for years, resulting in high levels of IgM and IgG in the serum. Physical findings at this time may include tachycardia, generalized lymphadenopathy, especially Winterbottom's sign, posterior cervical adenopathy, splenomegaly, transient edema of the face and extremities, and a non-pruritic circinate rash beginning approximately 6 to 8 weeks after the onset of illness. The patient usually develops a normocytic normochromic anemia and monocytosis. Thrombocytopenia is common. Over time, the episodes of fever are associated with lower temperatures and less severe systemic symptoms. Trypanosomes can multiply in the interstitial spaces and infiltrate virtually every organ. Pancarditis occurs more commonly with East African trypanosomiasis. Meningoencephalomyelitis stage 2 is the hallmark of the infection and eventually occurs in all patients who survive the acute stage. Trypanosomes may invade the brain, resulting in edema, hemorrhage, and infiltration with lymphocytes and plasma cells. Mott or morula cells found intraparenchymally or in cerebrospinal fluid are thought to be plasma cells packed with immunoglobulin, predominantly IgM. The patient loses motivation, initiation of spontaneous tasks, and becomes irritable. Decreased concentration, changes in mood, and somnolence occur, and are usually progressive. There is a propensity to sleep, hence the designation sleeping sickness.
Psychosis also may develop. Extrapyramidal signs such as tremors of the tongue and extremities, ataxia, fasciculations, choreiform movements, slurred speech, and hypertonia usually occur. The spinal fluid usually has a lymphocytic pleocytosis with elevated protein and Mott cells. IgM may be detected. Progression leads to malnutrition, coma, and death from pneumonia or another infection.
Some patients with West African stage 2 disease may present without a clear-cut history of onset. Parasitemia is low. Fevers are generally lower than in East African trypanosomiasis. Early debility is infrequent, and meningoencephalitis occurs late. In contrast, the typical patient with East African trypanosomiasis presents with a more fulminating disease. Parasitemia is usually high. The fevers are high. Early debility is frequent. The illness is more frequently confused with malaria or typhoid fever. Meningoencephalitis occurs early. Some even die before developing stage 2 disease. Despite these differences, the syndromes of East and West African trypanosomiasis may overlap and cannot be differentiated clinically. The diagnosis of trypanosomiasis should be suspected when a person has a proper geographic history, symptoms of intermittent fever, posterior cervical adenopathy, and a greatly elevated serum IgM. Features that are almost diagnostic are cerebrospinal fluid with increased lymphocytes, elevated protein, and detectable IgM. However, a definitive diagnosis can only be made by identifying trypanosomes in a body fluid. In fluid aspirated from a chancre or lymph nodes early in the infection, trypanosomes may be detectable either as motile forms or on a Giemsa-stained slide. Thick blood smears and the buffy coat, which is more sensitive, should be examined. Giemsa-stained smears of bone marrow may also demonstrate the organism. Cerebrospinal fluid can be centrifuged and the pellet examined for Mott cells and stained for trypanosomes. Numerous examinations of blood and cerebrospinal fluid may be necessary to discover an organism. Cerebrospinal fluid should always be examined to determine if the disease has progressed to stage 2.
The only way to differentiate between East African and West African trypanosomiasis is by the geographic history. The tsetse fly bite is painful, and most American travelers will be able to tell exactly where and when they were bitten by the tsetse fly. African residents who have been exposed in both East and West Africa are rare.
The treatment of trypanosomiasis is based on the stage of the disease and the ability of a drug to penetrate the central nervous system. Stage 1 disease due to Trypanosoma brucei gambiense can be treated with pentamidine, suramin, and eflornithine. For stage 2, the drug of choice is now eflornithine. This drug inhibits the metabolism of the trypanosomes but does not kill the protozoan. Thus, host defenses must ultimately destroy the compromised trypanosomes. Stage 1 Trypanosoma brucei rhodesiense can be treated with suramin. Stage 2 is generally treated with melarsoprol. Since these drugs have potential serious side effects, physicians with experience in using these drugs and treating these patients should be consulted. It has been recommended that clinical examinations continue through the first year following treatment. Spinal fluid examinations have been recommended at the end of treatment and at the 3rd, 6th, and 12th month thereafter.
Since Mr. Tomas had West African trypanosomiasis, I treated him with a recommended dose of eflornithine for 16 days. By the day following treatment, his spinal fluid had improved. By 6 months post-treatment, his symptoms, neurological examination, and spinal fluid were essentially normal, and he has continued to be well 1.5 years after treatment. Fortunately, African sleeping sickness is rarely seen in the United States. However, as populations shift all over the world, physicians should be alert to the unusual signs and symptoms which may indicate the presence of African trypanosomiasis.